Hello, my name is Dr. Yelena Janjigian. I'm a medical oncologist and chief of GI oncology service at Memorial Sloan Kettering Cancer Center in New York City. Welcome to this activity on the role of HER2 as targetable biomarker in GI cancers. In this first presentation, we're going to look at the clinical significance of different HER2 alterations across multiple GI cancers, and we'll discuss best practices to optimize testing based on the latest evidence and the recommendations. Well, HER2 is an important biomarker because it's a transmembrane receptor and part of the four-group receptor superfamily. HER2 and HER3, of course, EGFR, which is HER1, and HER4. Once the ligand binds to the HER2 receptor, it dimerizes with HER3, which is its preferred dimerization partner, and then it activates RAS MAP kinase pathway with multiple downstream targets, of course, including RAS, RAF, MEK, and PI3 kinase cascade. For over a decade, we knew that this is an important biomarker in many GI cancers, and there's several different alterations that are seen that result in aberrant signaling. We commonly see HER2 alterations detected on next-generation sequencing, including amplifications or mutations, both extracellular domain and intracellular domain, where the phosphorylation happens. And of course, by protein overexpression, overexpression of this receptor, we see using immunohistochemistry, both IHC3 plus or IHC2 plus, and then on fluorescent in situ hybridization, FISH amplification seen. So all of this results in an oncogene-driven tumor, and similar to breast cancer, certainly across GI cancers, we see the increased tumor growth, which leads to being able to target and overcome this pathway in gastroesophageal and other GI cancers. So the tumor prevalence of HER2 alterations across these cancers is variable, and I think some of it depends on the biomarker, the type of the biomarker done using either sequencing NGS or overexpression. But you could see here there's a wide range of the biomarkers seen in biliary tract cancers, typically at approximately 5%, as low as 5% of the cancers, versus gastroesophageal and GE junction tumors as high as 30%. In more common cancers, such as colorectal cancer, where even though it's a rare subgroup, about 3 to 5%, of course, because 200,000 patients, in the United States are affected by this disease, these biomarkers are still very important. In GI cancers, gastric and gastroesophageal adenocarcinoma was the first sort of biomarker-driven population that led to the FDA approval of these drugs, and now rapidly, even in targetable alterations in difficult to target cancers like PDAC and BTC cancers, and certainly CRC, but colorectal cancer, these studies suggest that this is an oncogene that can be targetable. Well, certainly in different tumor types, we understand that the co-occurring alterations can affect the response to HER2-targeted agents, but the recommendation both from European societies such as ESMO, the NCCN, the US societies, recommend routine testing of all GI cancers, including biliary tract cancer, gastroesophageal cancer, and colorectal cancer. And this is considered really firm evidence and based on FDA and EMA approval of drugs in this space. Drugs like trastuzumab deruxtecan that is approved irrespective of tumor origin for HER2-driven tumors. Of course, trastuzumab and tucatinib and so forth. The only caveat is PDAC. The NCCN is much more broad on it and includes it, while ESMO is still not firm on testing. So what are the routine tests that we can do? Starting with immunohistochemistry, it's a very simple test, can be done on single unstained slides. And HER2 IHC scoring ranges from 0 to, so 0 expression to IHC 3+, which is positive, strong basolateral expression. The caveat is that historically these tests were developed in breast cancer. And so in breast cancer, because of the nature of the epithelium, the staining and the cytoplasmic versus basolateral staining can be slightly different. And so when the drugs were initially approved in GI cancers, there was a bit of a learning curve and somewhat of a hesitancy of pathologists to routinely order these tests. But now it's level 1 evidence that supports immunohistochemistry testing. And certainly, practically in the clinic, our GI patients can be quite sick. We need to act on their treatments relatively quickly and treat these patients quickly. So having the IHC test handy is very helpful. It's the cheapest of the available tests, and that's what we start with, particularly for gastroesophageal cancer. If IHC is borderline or IHC 1 plus, IHC 2 plus staining, typically fluorescent in situ hybridization is done, which takes a few more days, and it looks at the centromere and the chromosome copy and counts the ratio and if the ratio of the chromosome to centromere is greater than 2, so let's say it's 14/7, it's inconclusive, but if it's 21/7, it's clearly amplified. ISH is 3, and the tumor is positive. Of course, next generation sequencing is entering the market very rapidly because the cost is reducing, and most institutions have access to either as a sent out or internal test for these comprehensive gene panels, and it gives you an advantage of knowing co-occurring alterations with HER2, for example, in tumors like PDAC or colorectal cancer, where these alterations co-occur with RAS and then may not be as targetable with HER2, for example, with certain drugs like tucatinib or trastuzumab. T-DXd, interestingly, has activity irrespective of RAS status, so may be an interesting, important factor. The other test, the circulating tumor DNA, has been really quick and easy and relatively cheap. The current challenges and the limitation of the tissue is really still there. How can we address this in the future? Well, getting the testing done early on before the tissue is exhausted, I think, is the best way to do it. And horizons on to improve this is really using circulating tumor DNA as much as possible in conjunction with, standard tissue, knowing that circulating tumor DNA will not replace standard tissue testing, but it certainly is an option. Why won't it replace ctDNA? It's because that the ctDNA assays are designed typically for mutation-based testing, and for amplification, it may not be as good. So for HER2 mutations, it's very good to detect KRAS alterations, mutations, other RAS alterations, but not necessarily HER2 amplification, so you may miss an amplified tumor. So the highlight of our seminar is to really understand that HER2 is a uniform tumor-agnostic biomarker in GI cancers. We have FDA approvals of agents irrespective of tumor origin in GI cancers. So similar to microsatellite instability, for example, when you see a GI tumor, as a pathologist or a patient with gastrointestinal tumor in the clinic, you need to think reflexively to test for HER2. Sobering data shows that not all patients in the United States, and certainly not Europe, even where access to these drugs is available, are getting tested. And again, immunohistochemistry is a relatively straightforward test. We typically test our patients early, even in their disease course, because that's when the tissue quality and tissue availability is the best. And data suggests that what you start the patients on and how you treat them early in their course really affects the likelihood of survival. So really, thank you for participating. It's an important biomarker, HER2, and please test your patients.
Hello, I'm Professor Erik van Cutsem. I'm a GI oncologist at the University of Leuven in Belgium. And I'm happy to join you on this webinar on HER2 targeted therapies. And we saw indeed in the previous presentation that testing for HER2 alterations is critical in patients with GI cancers. as we have a growing number of targeted therapies that we can use to improve outcomes in these patients. In this presentation, we will review the latest evidence with HER2 targeted therapies approved in gastric cancer, and I will briefly also highlight some of the new treatment options with HER2 targeted therapies in other GI cancers, because there is a lot of activity ongoing. If you look at the timeline, it started in GI cancer with the TOGA study that I had the privilege to co-chair together with Yung Bang from Korea. In the TOGA study in 2010, we showed that the addition of trastuzumab to chemotherapy in HER2 positive gastric cancers was led to an improved outcome. It's only since the last 3 years that we see new data coming through, starting with the antibody drug conjugate trastuzumab deruxtecan. Also afterwards, pembrolizumab and trastuzumab in HER2 positive gastric cancer. And then even more recently, we saw interesting new data in different other tumors, other GI tumors, such as the zanidatamab data in bile duct cancer, the tucatinib trastuzumab data in colorectal cancer, and then also some pan-tumor data in different cancers, including different GI cancers with trastuzumab deruxtecan. And if we focus on some of the data, one of the pivotal studies after the initial TOGA study was the Keynote 811 study, which was a study of first-line treatment of advanced gastric cancer in patients who were HER2 positive, defined with the classic criteria, immunohistochemistry 3+ or 2+, followed by a positive FISH test. And in this study, we have shown that the combination of chemotherapy doublet plus trastuzumab plus pembrolizumab was more active in HER2 positive and PDL positive tumors compared to the trastuzumab chemotherapy combination. The initial design of the study was there for all comers regarding PDL status, but then later analysis showed that the positivity, the benefit was clearly there for patients with a PDL positive tumor. So on the other hand, we do know that 85% of the HER2 positive patients have a PDL positive tumor. So this brings a new treatment option for the patients with an especially aggressive tumor. First-line gastric cancer, the prognosis is dismal. If you look at that a few years ago, the median survival was less than 12 months. With the TOGA study, it increased a little bit. And now we are over around 20 months with pembrolizumab, trastuzumab, and chemotherapy. This became a new standard. We have seen also different important studies with trastuzumab deruxtecan in second line, and also some studies second and third line treatment of HER2 positive gastric adenocarcinoma. And very recently, we have presented and published the data of Destiny Gastric 04 study evaluating trastuzumab deruxtecan versus ramucirumab paclitaxel in HER2 positive metastatic gastric or G-junction adenocarcinomas, patients who were previously treated with trastuzumab-based therapy. So we have clearly shown that there was a survival advantage in the Destiny 04 study for trastuzumab deruxtecan compared to ramucirumab paclitaxel. Median survival is between 14 and 15 months. So that's important. So that means that more than 50% of patients will be alive at 1 year. There was also a progression-free survival and response rate benefit in favor of trastuzumab deruxtecan in patients pre-treated with trastuzumab-based therapy in the second-line setting. So that's in gastric cancer, a lot of activity is ongoing, but also expanding that to other GI cancers. A few examples are the zanidatamab data. This is a bispecific antibody binding to two different epitopes of the HER2 receptor. This study was in bile duct cancer. It's a phase 2 study showing a high response rate of more than 40% in HER2 positive biliary tract cancers. Tucatinib plus trastuzumab was active in pretreated HER2 positive colorectal cancers with response rates approaching 40%. And then we have seen a very important study, which is the Destiny Pan-Tumor O2 study, which is a relatively large study, different cohorts, different tumor types. And also in this study, we saw that, for instance, in bile duct cancer, but also in other cancers, there was a high activity of trastuzumab deruxtecan, leading to a tumor approval in some regions after this trial. The different drugs that we use may have different safety profiles. In general, we can say that the different drugs that are used and evaluated and have shown activity, that they have a manageable safety profile. The addition of pembrolizumab to trastuzumab and chemotherapy gives, of course, a little bit more IO-related side effects. In the Destiny 04 study that was recently presented and published, we saw also that if you look at the treatment-related adverse events or the more severe treatment-related adverse events, or the number of treatment discontinuations, there was no clear difference between trastuzumab deruxtecan and ramucirumab paclitaxel. The profile of adverse events was slightly different, but with trastuzumab deruxtecan, to focus on the HER2 targeted adverse events, this was the main toxicity, or the most important toxicity, is the interstitial lung disease, which occurs across different trials in around 10 to 12% of the patients. This is acceptable, but of course, good education and an adequate management of clinicians is relevant. Zanidatamab, the most important toxicity, and that's more important in other studies where zanidatamab was combined with chemotherapy, is diarrhea. And especially there was a phase 2 study of zanidatamab plus FOLFOX, where there was a bit more diarrhea than what is shown in the Horizon study in bile duct cancer, where it was in monotherapy. Trastuzumab tucatinib is mainly GI toxicity already, and trastuzumab deruxtecan also in the pan-tumor was also ILD, interstitial lung diseases, to be looked at in detail. And then, of course, there are some chemotherapy-related toxicities. So different safety profiles, all feasible strategies, and in these different indications with HER2 targeted agents, different but acceptable toxicity profiles. Bile duct cancers are a relatively rare tumor type with an extremely poor prognosis. And until a few years ago, we had only gemcitabine or gemcitabine cisplatin, which then became the standard treatment for these patients. Recently, we have learned that looking at molecular analysis, doing NGS panels, and looking for HER2 also is extremely important for these patients. In generally, we see that around 1/3 of the patients have a druggable molecular alterations, going from FGFR fusions to IDH1 mutations, and then more recently also the data on HER2 on BRAF, which are relatively rare alterations. For these patients, if we don't find one of these molecular alterations, we can only treat them with chemotherapy. Usually we detect that in second line treatment, so after progression on gemcitabine cisplatin. And in second line, the reference, I don't dare to say the standard treatment, but the reference treatment is the regimen of FOLFOX, which has a median survival of less than 6 months in the different studies. And now with these targeted agents, and here we're talking on HER2 with zanidatamab, but also with trastuzumab deruxtecan, we see median survivals that are more than a year. We see in 35 to 40 and 40 plus percent of the patients an objective tumor regression. This for all patients in whom the tumor is progressing before, and then we see a tumor regression in these patients, leading to symptomatic control in some of the patients, and leading to a clearly impact on the outcome in this group of patients with a very poor prognosis. So it's clear that a molecular analysis is important in different GI cancers. And one of the molecular alterations that we're looking at is HER2, because HER2 is a driver in different GI cancers, gastric cancer, colorectal cancer, bile duct cancer, but also there are tumors such as small bowel cancer. And for these different tumors with HER2 positivity, we have clear new agents, antibody-drug conjugates such as trastuzumab deruxtecan, bispecific antibodies such as zanidatamab, or TKIs such as tucatinib, but then in combination with trastuzumab. They're clearly active, and so the message for the clinicians is clearly that we have to understand the molecular alterations, we have to do testing for HER2, and we have to use the appropriate drug in these different indications.
Hello, my name is Florian Lordick. I'm a medical oncologist, a professor of oncology at the University Cancer Center in Leipzig. I'm treating patients with gastrointestinal tumors since many years. I'm very happy to be with you today. I must say that since several years, we are using HER2 as a tumor-agnostic biomarker. We are testing almost all patients with GI tumors for the overexpression of HER2 or the amplification of HER2. And we have more and more indications where we are able to use HER2-targeted treatments, such as the combination of trastuzumab with or without pembrolizumab in first-line gastric cancer, trastuzumab deruxtecan, which is now approved and used for second-line metastatic gastric cancer and beyond. But we also have the options in biliary tract cancer, trastuzumab deruxtecan, or also zanidatamab. And colorectal cancer, it's an emerging field. Also, not so many patients present here with overexpression of HER2, but if you find it, you have very valid options for that. Liquid biopsy is at the horizon, but not that much integrated into the routine of our center. Everything currently is more based on tissue diagnostic, and the crucial point is really to get enough material. I must say that our endoscopists, they know that in suspicious lesions, they should take enough biopsies. If there is real suspicion for tumor, we have in our standard operating procedures that they should take 6 or even more biopsies to ensure that there is enough material for doing all the biomarker testing, such as staining for HER2. we have learned, especially from studies that have been done in gastric cancer, that if patients have been exposed to previous HER2 targeted treatments, up to 30%, or in some studies even more, are losing the HER2 positivity of their tumor probe. So that's something we are always doing when we are intending, when we have the option to use a second-line HER2-directed drug, such as trastuzumab deruxtecan in second-line gastric cancer. We try to obtain new material and are retesting. It is such an important point to treat our patients safely. And I must say, I mean, in oncology in general, we are very used to treatments which are toxic. So an adequate monitoring of toxicity is something the whole team is trained to do. But there are some specificities when it comes to HER2 targeted treatment. And let's go through some of them. For instance, the first-line combination of trastuzumab, pembrolizumab, and chemotherapy, as studied in the Keynote 811 study, clearly shows us, and you can see this here, that we have to count with some form of toxicity in almost all patients. So that's really not the exception. It's routine that we need to monitor patients and that we need to treat toxicity. And when we are going a bit into details, we are seeing that there are diverse toxicities that can occur with the combination of trastuzumab and pembrolizumab, starting with infusion reactions, something acute, which happens in the treatment room that we need to treat acutely. But we also need to look for all the immune-related reactions, such as diarrhea, colitis, which can be caused either by the immune checkpoint inhibitor, but also by trastuzumab. And pneumonitis, lung toxicity, is an important field, not very common, but it can become very dangerous. So it's really important for the whole team to know that. And if anything is suspicious, of course, halt the treatment, do the diagnostic, consult with the specialists, with the experienced ones in the team, and treat the condition before you go on with the treatment. Or in some patients, you also have to hold it for a longer time or stop the whole treatment. There are, of course, also other drugs that are now regularly used. One of those, an important one, is trastuzumab deruxtecan, an antibody drug conjugate. And beyond toxicities we have already managed, I want to put the focus here on interstitial lung disease and pneumonitis, because this is really an issue for many of the antibody drug conjugates that we are using, but also particularly for trastuzumab deruxtecan. It's quite common. More than 10% of our patients experience pneumonitis, interstitial lung disease at any degree. And as compared in the Destiny Gastric 04 trial, it was compared to ramucirumab paclitaxel. This is really more common than with the previous standard of care. We also have to monitor for left ventricular dysfunction. It's less common than pneumonitis, but we also need to look at that. And I think one of the important questions is really how do we do that? In principle, I must say we are doing it exactly like it has been proposed in the studies. We are monitoring regularly with every visit. We are asking the same questions. Did you experience shortness of breath, new cough? Is there anything that is different compared to the time before? And this means if there is any sign of an alteration, we are doing a CT scan. That's really crucial. A high resolution CT scan is showing best where the patient stands. We can also do blood gas analysis, lung functional test, but the CT scan is really very, very important. We are in general, with our patients who present with metastatic disease, we are monitoring them for response every 6 to 8 weeks. So we have some regular monitoring, but if there is anything in between, we are doing an extra scan. And then we hold treatment. If there is suspicion, we are doing extra diagnostic, and we are treating the condition as good as we can, usually including with steroids. They play an important role here. maybe we should also shortly talk about the combination of trastuzumab tucatinib. Also, I must say, tucatinib is not yet approved in the European Union for the treatment of patients with HER2-positive gastrointestinal cancers. It's approved by the FDA. This combination also has its side effect. Diarrhea is maybe the most important in the clinical context. Also, hypertension can be associated with this combination. So another combination that has professionally be screened for various side effects, but not yet as common for centers in Europe. Zanidatamab, very interesting a novel drug, a bispecific antibody, which has recently been approved by the FDA to treat patients with HER2-positive biliary tract cancer. Different from other HER2-targeted treatments, it seems that it has a much stronger rate to cause diarrhea. There is a strong immune reaction at the level of the gut. So these patients treated with zanidatamab, I personally know it from studies we are doing with this drug, the monitoring of diarrhea and halt the treatment if there is diarrhea, treat diarrhea is one of the most important issues in the context of zanidatamab. But otherwise, that's a very interesting novel drug that may play a role in the future. HER2-targeted treatment has become a busy field. We are really seeing a lot. And we have been talking now about the classical antibodies such as trastuzumab, antibody drug conjugates such as trastuzumab deruxtecan. We have been talking about bispecific biparatopic antibodies such as zanidatamab. I would still like to mention that a novel tyrosine kinase inhibitor, songertinib, is producing very promising data. I'm curious about that development and also about the development of cellular therapies. We are working a lot here in Leipzig with cellular therapies. We have a big production facilities. So I'm curious to see the first HER2 targeted cellular therapies coming into clinical practice. And then another field where I'm interested in, most of the patients we have currently under treatment present a strong expression of HER2. And we have seen developments in breast cancer where also low expression profiles are sensible to HER2 targeted treatments such as antibody drug conjugates. Trastuzumab deruxtecan has made the way in breast cancer. So I'm looking forward to see more data in GI cancers. We have some reports about preliminary activity, but more needs to be seen and studied there. The most important takeaway is certainly think about HER2 and think about it universally. It's a tumor agnostic biomarker for GI cancers, and so test for it in the patients that you're seeing. Second takeaway, the side effects usually are manageable. We have to think about some particularities, such as pneumonitis, such as diarrhea, such as cardiac side effects. But if you think about it, if you screen for it, if you scan for it, that's usually manageable. And yeah, be open to the novel strategies which are coming. There is a lot going on in this field.